Hi, and welcome to you all to this relaunch of the Royal Marsden Partners Future Focus webinars. It's lovely to see you all. And can I say happy Cancer CNS Day for our CNSs yesterday, and a warm welcome to all our AMP and Pan London colleagues. We're going to continue with a lunchtime slot for the next few webinars, but we welcome any feedback to timings and structure for future programmes. So please do complete the feedback form sent to you. Elaine is online, my colleague, and she's going to facilitate any questions at the end of each talk. So please write in the chat bar any questions you may have. We have two fantastic speakers this afternoon. We have Dr. Paul Farquhar-Smith, a consultant in pain management and anaesthetics at Royal Marsden Hospital with a special interest in peripheral neuropathy, and Mary Tanei, a doctoral research fellow at King's College London and a board member of UConns. So I'm going to hand you over to Mary, and we welcome any questions. Thanks.
Thank you, everyone. Hello, my name is Mary Tanei, and thank you for this opportunity to be able to share with you some of the research and also the work that I'm doing about chemotherapy-induced peripheral neuropathy, focusing on patient experience. So first of all, let's just talk about what is peripheral neuropathy, or I'll call it CIPN or neuropathy in this talk. So it is a broad term that we use to name nerve damage that is caused by chemotherapy. So it is a side effect of many neurotoxic chemotherapy that we use, and it affects mainly the hands and the feet. The symptoms include some sensory symptoms such as dysesthesias, paresthesias, cold allodynia or hyperreflexia. And although we hear all of these terms, we usually use the terms numbness and tingling and also pain when we are describing symptoms of neuropathy. Patients may also experience some motor weakness. And although most of the symptoms are mainly on the hands and feet, some of our patients may also experience other symptoms such as hearing issues or hearing loss, or also autonomic symptoms such as dizziness or orthostatic hypotension. So as I've mentioned earlier, chemotherapy induced peripheral neuropathy is a common symptom. However, not a lot of people are aware of it. But if we look at the incidence of CIPN, we can see from a review by Saretny et al. In 2014 that about 7 out of 10 patients will experience CIPN a month after chemotherapy. About 6 out of 10 will have CIPN still 3 months after chemo, and 3 out of 10 will experience 6 months or longer after their treatment have finished. And the reason why it is common, but we don't know, is because the symptoms are invisible. And if I show to you the list of drugs that usually cause a CIPN, you will recognize a lot of this. So for example, platinum-containing drugs, oxaliplatin, cisplatin, and carboplatin, they're effective against many solid tumors. And just oxaliplatin alone, if we think about oxaliplatin, that causes acute CIPN up to 85% of the patients, and chronic CIPN up to 73%. Taxanes, paclitaxel, and docetaxel, these are given for ovarian cancer, breast cancer, and non-small cell lung cancer. And you might recognize bortezomib, which we use in multiple myeloma and lymphoma. Bortezomib causes painful or neuropathy, which causes like about 50% of patients treated will experience moderate pain, and about 30% will experience severe painful neuropathy. I could go on this long list, but as you can see, our patients may experience neuropathy, and overall it's about 15 to about 90% of our patients may experience CIPN. So in terms of the nature and severity of a CIPN, let's just focus on the nature of symptoms first, because there's a lot of different symptoms. But these symptoms, the nature of them usually is dependent on which part of the of the nerve or the peripheral nervous system has been affected by the drug. And there are different points that each drug might affect. And you can see this on this photo. And I won't go through this, but you can look at these really good reference, Park et al. In 2014 on the explanation of those areas. But overall and in general, the mechanisms of CIPN are caused by, they happen, CIPN happens in different mechanisms. It could be because of microtubule disruption, mitochondrial dysfunction, axon degeneration, the altered calcium homeostasis, changes in peripheral nerve excitability, or it could be an immune process and some inflammatory mediations. And it is believed that central mechanism involving the blood-brain barrier may also be involved. So there are several factors that affect risk and severity. So in terms of, there are two categories that I've put here. The first one are the treatment-related factors. So those factors include the dose per cycle, the cumulative doses, the duration of infusion, and overall treatment duration. So I think in terms of cumulative dose, for example, for paclitaxel, about if a patient had about cumulative dose of 302 milligram meter per square, then they may already develop a paclitaxel. And for docetaxel, that goes up to 100 milligram per meter square, and then they can experience mild neuropathy. But for paclitaxel, which is the more neurotoxic between the two, if the cumulative dose goes up to 1,000 to 1,400 milligram per meter squared, then the patient may experience grade 3 CIPN. Whereas for oxaliplatin, 70% of patients who are treated with about 540 milligram per meter square will already experience CIPN. Now, in terms of patient-related factors, although the evidence is still very low in some of these factors, there is evidence to show that older age may be a factor. However, this is not. I mean, there's a lot of conversation about this because most of the clinical trials involving these drugs did not include older patients, and so the hypothesis was that this the neuropathy was actually a part of being old, and that it is just a comorbidity rather than caused by the neurotoxic drugs itself. Some comorbidities, such as diabetes, if patient has already neuropathy due to diabetes, that could be accentuated. The symptoms may be aggravated because of us giving neurotoxic drugs. Some nutritional and electrolyte deficiency might also cause neuropathy, and electrolytes, vitamins such as vitamin D were shown to affect the severity of neuropathy. However, when we looked at the different studies, the approaches and the methods that were used and the outcomes that were used were not really similar. Therefore, it's so difficult to create an absolute judgment on whether they are really factors that affect the risk and severity. In terms of race, there's about a couple of studies that highlighted that patients who are of African American background may have increased risk of developing neuropathy. There are also some genetic profiles that are being looked at, although still very early stages, that may predispose patients to developing neuropathy. And obviously, previous chemotherapy, especially if their patients are given neurotoxic drugs, may again increase the severity of neuropathy because of that cumulative effect. And there are evidence also that obesity and the lack of physical activity may also increase the severity of CIPN. And as I've mentioned, a lot of these factors are still being looked at, and the evidence is currently low. Now, in terms of symptoms, patients describe their symptoms by using analogies. And I'm sure for those of you who are looking after patients who receive neurotoxic treatments, you may have already heard a lot of these descriptions that patients use. So they say numbness and tingling, it's like having pins and needles on their hands or their feet. It's like a burning sensation. And one patient even mentioned that it's like walking on pebbles or like a cushion wherein you can feel some of the soles of your feet can feel the pebbles, but then some areas are still numb. Some patients also mentioned about the feeling of ants crawling up and down their feet up to the level below their knees. So a lot of patients say that it feels like it's an unclear experience, and for those who can't remember that they have actually heard this from their clinicians before, they thought that they were just imagining symptoms. And most of the symptoms are invisible. So this just becomes visible to the people around these patients when, as clinicians, we ask them, obviously, but also when these already start affecting their day-to-day activities. A very common thing that description of it that I get from patients is that they lost their hand grip, and a lot of them are spilling their teas and coffees. And this picture here was co-developed with a lot of patients, and for a lot of them they said that at some point they have dropped a cup of tea or a cup of coffee, and a lot of them as well said that they have dropped valuable fragile things when they as a result of their lack of hand grip. Some patients also recognize that their handwriting is not as legible as how it were before. So in terms of impact on quality of life, and this is why it is important that we talk about neuropathy, patients in quality of life is affected, and this we can say that this impact may be acute and it could be chronic. And I think for acute peripheral neuropathy, it is important that we highlight this to our patients. Acute painful neuropathy may happen 3 days after infusion following treatment with paclitaxel. And it is good to highlight this to patients so that they know that this might happen. For patients who are receiving oxaliplatin, they may experience acute neuropathy. About 90% of patients receiving oxaliplatin will develop cold-induced dysesthesias. So when they go out, when the weather is really, really cold, they will feel this paresthesias on their hands and feet. Some patients even can't tolerate holding their metal cutleries because of that sensation. And for some patients, they become really surprised by it. So it is good to highlight it to them. A lot of the symptoms also happen acutely when patients are receiving their treatment. So this numbness and tingling, they happen while patients are still on their cycle. And this is good because we are there, that patients are coming every week, every cycle, or in clinics. So we are able to support them. But what I would like to really highlight here is about chronic CIPN, because once the patients are discharged in the community and once they are at home, then it is important that patients are really ready and really empowered in terms of managing their symptoms at home when we are not there to help them out and to answer their questions. So CIPN, the patient experience data that we have looked at and the literature that we have shows that it causes negative impact on the quality of life of patients, physical function and performance of daily activities. Patients who have received paclitaxel are also 3 times more likely to experience falls as compared to those who haven't received paclitaxel. Patients have reported that their domestic life is affected, their work has been affected, and this can also cause economic losses because some patients, there was one research wherein a patient who's a surgeon had to give up their work completely because of the fine movement that they can't deal with when they have to perform their operations. And just think about the things that we hold, the things that we do on a day-to-day basis, just us, like using our computers, our mobile phones, and some things, tools that we use at home and at work. So this can have a real severe consequence on patients, especially when it lingers, when CIPN lingers after their treatment. Now, the reason why it becomes, again, challenging is because pharmacological approaches for prevention and treatment of CIPN are either limited or inexistent. So in terms of prevention, there's nothing that is recommended by ASCO guidelines for the prevention of CIPN. And for treatment, duloxetine is the only agent that they recommend as appropriate for patients with established CIPN. Now, another guidance that we have is the ESMO EONS EANO clinical practice guidelines, and this is they are showing similar recommendations. There is no effective agent that exists to prevent CIPN, and that there are effective options. Again, duloxetine is also mentioned, but this is only for moderate clinical benefit in patients with painful CIPN. ESMO also recommended topical low concentration menthol cream, and they recommended this because it is of low cost, and also there are not a lot of adverse events. So in a way, I wouldn't say that we're stuck, but in a way, in terms of pharmacological approaches, we are a bit stuck here. So what we want to happen is that our patients' symptoms are hopefully less, and that if they happen, then we can help them manage their symptoms. So the approach that we are doing is if patients report CIPN and it becomes severe, then the patients and clinicians have to sit together and think about dose reducing or dose delaying in order for the CIPN symptom to be less severe, hopefully, and it does not affect them long term. So it is important that we highlight to patients that they report their symptoms when these happen. So as invisible as the symptoms are, we have to encourage them to report them, that not when they start feeling the symptoms, then they have to mention it so that we can keep a log on whether this is getting worse or maybe it is okay to continue with treatment and we don't need to do dose modifications. Patients have to engage in discussions about making decisions about their about their treatments. And if symptoms are already here, then we should be able to provide them with support to reduce the impact of CIPN on their quality of life, their safety, and their physical function. Now, why are patients not self-reporting? And it all in our research that we have done using the common sense model of how patients really develop these representations of CIPN, their perception of CIPN is actually affected by a lot of factors. And this bit here is what I would like to highlight to you, to healthcare professionals such as myself. It's about the message that we give to patients and how we help them develop their perception of CIPN so they are able to deal with the symptoms and also hopefully able to cope. So in terms of the social context of CIPN, one that I would like to highlight is that the general public were perceived by patients as lacking in awareness of CIPN. One patient even said, if you pull someone on the streets, they will know that chemotherapy causes alopecia, hair loss, or nausea and vomiting. But if you mention to them about neuropathy, they wouldn't know about it. They might not even heard about it. And certainly for patients, the first time most of them heard about neuropathy is when their clinicians mention it to them. The patients also said that they are so dependent on the CIPN knowledge and descriptions and attitudes of clinicians. And when we spoke to a few clinicians about neuropathy, it seems like the focus are more on acute symptoms, and maybe because that's what we see on a day-to-day basis, and perhaps the chronic symptoms might be something that may be overlooked because of the current challenges that we already have in managing with the other symptoms and the other side effects of chemotherapy. But patients also highlighted that when CIPN is mentioned to them, it is relatively insignificant in comparison to other side effects of treatments. And I'm not saying here that we should amplify the risk of neuropathy, but maybe ask ourselves, what message are we sending to patients when we explain about neuropathy? A lot of patients said it's actually down at the bottom of the list when they give me the information sheet. So this gives them an idea that actually maybe that's not important. Clinicians also mentioned that they are dependent on patient reporting the symptoms. So sometimes this is not, it does not become visible as a problem, but also the difficulties and challenging providing support. And patients actually see this and they felt like, if we can't do anything, then what's the point of reporting? So it's a matter of like thinking, what message are we sending to our patients? And obviously for patients, some of them think neuropathy, yes, I can deal with that. And as long as I get rid of the cancer, that's fine. I can deal with neuropathy. So we have to ask them, how important is this for you? Then they can make the right decisions. And obviously patients are more in favor they're less in favor of dose reduction because they want the maximum tumor control. And also because sometimes patients are overwhelmed with all the other life-threatening side effects, the neuropathy becomes like a less problem that they have to deal with, and something that they have to deal with later on. But as I've said, maybe we have to also think about the chronicity of CIPN and what might happen if we don't manage this. So really, we have to encourage conversations about CIPN, ask patients about what's important for them. Do they have other conditions? What are the existing problems with their walking and mobility? What things are working? Encourage them to talk to their doctors and their nurses, and help them to think about safety, and think about, when we do this, where do we refer them? So by asking these questions and making the conversations about neuropathy normal as part of our conversations with patients, then we can move on to assessment. And these are just some of the assessment tools that we have. These are objective assessment that clinicians might use. And there are also some patient-reported assessment scales that we can use. The one that I will highlight are the CIPN 20, which is CIPN specific, and the Pro-CTCAE, that is CIPN symptom specific, that focuses on numbness, tingling, dizziness, and severity. And it's a matter of like asking ourselves, do we go on a long list? This is an extract from CIPN 20. The CIPN 20 looks at the impact on the activities. Or we can also use the Pro-CTCAE when there are only a couple of questions, and then maybe if they answer something here that there's mild numbness or tingling, and there's moderate tingling, and then we can probe these symptoms further. There are also quantitative sensory testing when we refer our patients to neurologists, but the question is, when do we refer them to neurologists? But really, we would like to also highlight how patients can self-manage their symptoms, and this should focus on safety and maintaining their functions. And because pharmacological approaches are lacking, then we should also look at non-pharmacological therapies. One that has building evidence that that is helping with symptoms is exercise therapy. At the moment, there's no definitive prescription yet on what's the right exercise to give, although a lot of studies are happening at the moment looking at what is perhaps practical, what is effective in managing the symptoms. And maybe thinking about prehab in chemo, thinking about exercise and recommending it to patients even before the symptoms happen. And as we know, exercise there's evidence that exercise is effective in managing a lot of symptoms of chemotherapy. Therefore, there is also looking from the neuropathy side of things. It's practical that we recommend exercise therapy. One that perhaps I would highlight, that if there's anything you can take away from my talk, is about referral to physiotherapy and occupational therapy if that service is available, and maybe highlighting to patients that these services are available, and that when we refer them to occupational therapy, they may be able to be guided with mechanical aids that they might use. There are also re-education and sensory stimulation that our occupational therapists might introduce to them, and this is something that they can do at home. Physiotherapists may assess them for their gait and balance and recommend some exercise sessions for them. And the other areas, aside from physio and occupational therapy, are the benefits of acupuncture, reflexology, and massage. And I'm not saying that there is evidence already out there. There's limited evidence, but a lot of patients are mentioning about some benefits that they might get from it. So it's about highlighting this, and if it's available in your centers, then why not refer your patients to this complementary therapies. And just to mention to you that there's a large trial underway looking at cryocompression for the prevention of neuropathy. So watch that space. So I think in terms of summarizing this talk, so when I talk about improving the patient experience, there's a long list that we can look at. It's about providing information, encouraging shared decision making, thinking about what are the effective ways of assessment and putting there about talking about neuropathy, creating those conversations, thinking about the risk factors. At the moment, there's limited evidence. What are the nutritional deficits that increase the risk? We also have the challenge of lack of preventive interventions. We have limited pharmacological interventions, and non-pharmacological approaches are also limited. Maybe we should explore the role of complementary therapies. What practical advice can we use for self-management? How can we increase patients' capacity or opportunities? Are there any initiatives wherein we can give them some free vouchers to go to their gym to do some exercises, and also to help them to motivate them to self-manage their symptoms? Thinking about primary care support, a lot of patients are mentioning about perhaps this continuity between the specialist center and their GPs in terms of managing neuropathies. And when do we refer our patients to the other members of multidisciplinary team? And as I've said, physiotherapists and occupational therapists and neurologists and the other members of our team. So I think the summary would be to maybe challenge each and every one of you to look at what you have in your service and plan that service and make those services and use them to provide that service, and how we can improve those services in our areas. So I think that's all, and I just want to thank a few people who are on this slide and the NIHR for my studies. Thank you.
Thank you so much, Mary, for taking us through that. Really interesting. We've got a couple of questions, if you wouldn't mind. One of the questions is about what is cryotherapy. I know I was involved in a trial of cryotherapy and found the patients found it very difficult to tolerate. But do you just want to have a couple of sentences explaining what it is?
Yes, so cryotherapy is there's a device that it is the use of cold and compression pressure to hopefully lessen the effect of the drug to the peripheral nerves. So I think just to mention that there is a device by Paxman. I'm not advocating, but it's one of the larger trials that are happening at the moment. Paxman has a device which is a cryocompression device. Yeah. So if you want to look at that, it's on their website.
Yeah, it can be. The thinking can be it's a bit like scalp cooling, isn't it? Just to try and avoid the drug going to those peripheries. You were talking about dose and cumulative dose. There's a question about some people get peripheral neuropathy early in their treatment, whereas others it takes a while and suddenly it hits. So I guess the question is, it's either or. Is it it can be dose dependent, or it can be cumulative effect? Yeah.
Yes, so it could be that, because the as I've said, it's dose per cycle can also be a factor, one of the factors that increases the risk. And in most cases, it's cumulative doses, but also there's a phenomenon we call coasting, that even after the last dose has been administered, then that is still affecting the nerves, and it can take months even after they had received treatment, that there could be more damage to the nerves happening.
Yeah. And one final question: if there's a patient with significant CIPN, do you know of any support groups or forums that you might be able to signpost them to?
So at the moment, the forums that are available in the UK are mostly in several tumor-specific groups. So there's Overcome. I know that there are a lot of forums happening. There is no specific for neuropathy, unlike in the States, there is a neuropathy forum, but that is more of like a general rather than CIPN forum. I am also aware that some hospitals, I know St. George's has a neuropathy session, I think a 1 hour session that they deliver. So those are the only ones that I know about at the moment, although that seems like a great idea if we can have that forum.
Yeah. Thank you so much, Mary. I think we're out of time, but thank you for your insight, and remember to type your questions in the chat if you want to ask anything. I'll pass back to Lorna. Thank you, Mary.
Thank you.
Thanks so much, Mary. That was a really great talk and raised, the importance of us sharing the information with patients. So I'd now really like to welcome Dr. Paul Farquhar-Smith. He's a consultant in pain management and anaesthetics at the Royal Marsden Hospital. Welcome.
Okay, thank you very much for asking me to talk. Is it still working? Yeah, thank you very much for asking me to talk. I have a clinic that is dedicated to patients with CIPN, so hopefully I've got some idea what I'm talking about. This is just a gratuitous, nice slide from Scotland. These are my declarations of interest. I don't think there are any direct conflicts of interest for this talk. So we're going to talk about clinical bit. There will be some duplication after Mary's excellent talk, but I'm not apologising that, because hopefully it will emphasise the key points and maybe see it from a slightly different perspective from my perspective. So what is clear that it is under-recognised, and we've heard about some of the reasons for that, and both medical attitudes and patient attitudes, and we've certainly seen that, the examples of that as well. I've had people come to me saying, please don't tell the oncologist that I've got CIPN, without them realising that the oncologist had referred to me, but still, because they don't want to do that. And one of the main reasons is because they don't want to be considered for reduction of dose, which again we've talked about. It is very variable and can lead to dose limitation and stopping of treatment. There are a lot of different scoring criteria. I think we saw a few examples, and we're going into a little bit of detail about that. And we've also heard about the negative impact on quality of life and activities of daily living, which is true about neuropathic pain and certainly true about chemotherapy-induced neuropathic pain. Just for the sticklers of accuracy, I'm going to talk about chemotherapy-induced neuropathy, but that also includes the biological agents. But rather than saying the biological agent-induced neuropathy, I'll just say it as chemotherapy. And as we've also heard, there is limited proven treatment and preventive strategies. Risk factors, again, just for a refreshment: type of agent, duration of therapy, cumulative dose, combinations, and then anything else that puts your nerves at a damaged position or potentially damaged. Pre-existing neuropathy, of which CIPN can be one. So you can get worsening neuropathy if you've already got previous CIPN. And also, as also mentioned already, diabetes is a big risk factor, because even if you've got subclinical damage to your nerves from the diabetes, that gives you a risk factor for developing CIPN as well. So common features: symmetrical. Now that's quite important, because if you see purely unilateral symptoms and signs, then I would suggest it's not CIPN. You can get one side worse than the other, but really should have evidence of symptoms on both sides. You have this stocking glove distribution, as you do with diabetic neuropathy, and that's because it's thought to be the nutrient transfer is damaged in the nerves, and therefore the bits furthest away from where the nutrients come from die first. So that gives you that stocking glove distribution. Predominantly, although as Mary said, any nerve can be damaged, but predominantly they are signs and symptoms of sensory dysfunction. But as I said, you can get any motor, autonomic, etc. as well. it has variable recovery, and that's one of the important things I think we do, is actually by educating and giving patients a bit of knowledge about CIPN, they find that empowering in itself. What is clear that pain recovery and sensory recovery do not really match, and we're still working on the underlying mechanisms of why some people get painless neuropathy, but still very clearly and very debilitating, but also why some people get painful. And it's variable amounts of people who get pain, but ending from 20 to 50% and sometimes more. This sounds a bit obvious. Onset related to neurotoxic therapy. I've had people refer to me that haven't had any chemo. And as we've also heard, it can be rapid. There is the acute, which is thought to be different, but maybe is a risk factor. If you get an acute neuropathy, that doesn't necessarily mean you're going to get chronic, and vice versa. If you don't get acute, doesn't mean you won't get chronic. And then we've got this coasting thing, a lot of fun, not, because just when the patient thinks they've got away with it, they then develop or worsen their neuropathy after the cessation of treatment. And as I said, although motor can be affected, you can get sparing motor function. And what's interesting is those fine motor actions of the hands, they're often not actually motor weakness. They're just the fact that you don't have feeling and sensation in your hands, and therefore you drop things such as tea and coffee. So I would say I chose the usual suspects tagline first, but anyway, we won't get into that. So the usual suspects are the platins, the vinca alkaloids, the Taxols, Velcade, which we've already talked about, the bortezomib, which is a biological therapy, and oxaliplatin. Now, it used to be, Velcade used to be the major one that would come to clinic, but since they changed the dosing from IV to subcut, although the evidence is still controversial, certainly the numbers of people we see with Velcade-induced neuropathy has gone down, and oxaliplatin is probably top of the hit parade. And not for detail, just to tell you the sort of areas of cancer which we're talking about in the different vinca alkaloids, taxanes, and platinums. So obviously the main group in the taxane is the breast, platinums is the gut type, and vinca is the lymphomas, etc., and leukemias. This is a very quick summary of some of the aspects of these different types of chemotherapy-induced neuropathy. The plus in the onset time is coasting, whether or not they show coasting, and most of these do. And in fact, we have seen coasting with the Velcade. It's interesting how little is known about the natural history of each, but I think what we say to the patients, which is not too far away from the truth, is that after 2 years, about 2/3 to 3/4 of people will have some evidence of recovery. This is specifically for the chronic or the long-term neuropathy. And in the groups of the chemotherapies, there are the chemotherapies that are less problematic than others. So oxaliplatin, cisplatin is worse than carboplatin, paclitaxel is worse than docetaxel, etc. Thalidomide is an interesting one because it doesn't seem to have any dose duration or cumulative dose. You can get it whenever, and that's obviously common in people on thalidomide for maintenance of anti-myeloma treatment. So assessment, the issues are there's lots of different grading scales, and not all of them have pain in, which of course is not so interesting to me. There's no consensus of what one to use, and there's some suggestion that the different agents maybe need different scales because they can be quite different. The inter-observer reliability, i.e. people grading the neuropathy as the same with the different tools, is very bad. And again, only some bring into play the quality of life and activities of daily living, which we've heard, and quite rightly, is very important to the patients. And it's clear that symptom underreporting is a problem. We also talk about QST, the so-called quantitative sensory testing. The only trouble is that it may actually not be more sensitive than just clinical signs, which is a shame because it'd be nice if we had an early warning system. And also, given the full QST takes about half an hour to an hour, with each clinic that I have 12 to 15 or more patients in an afternoon or a morning, I don't really have time to do. We do a QST light, which is basically doing some kind of pinprick hyperalgesia, and light touch. But that's not to diss or give QST a hard time. It is objective, reproducible even, and there are studies. It's quite a useful tool to use in research, and it also gives you some insight into the mechanisms underlying what's going on. Now, this is I think, an interesting slide. These are different types of way of assessing CIPN with the types on the right. And you can see that the incidence is very, very different depending on which tool that you use. But it also shows how the incidence increases over time and how the same sort of proportions that Mary talked about are still there 3 months, 6 months, 9 months, and a year later. And this is in more detail specifically for cisplatin-induced neuropathy. And you can see there are huge differences slightly depending on what you use. So you have to be aware of that. We actually use the FACT-G, which although was made for the Taxols, it seems to be useful for other types as well. And then with oxaliplatin, similarly large differences in the incidence. So we just got to be aware that there are these differences. So we want them overly sensitive, but not underly sensitive. So I'm going to do a bit about the mechanisms underlying the science, but not much, just give you a sort of flavour of what people thinking of, because hopefully if we find a mechanism, then we've got some target to exploit with a therapeutic treatment. And I'm going to talk predominantly about pharmacological treatment since Mary's done the non-pharmacological treatment so well. And these are the key points that happen in the sensory nerve where these damages occur. So clearly you get dieback of the cutaneous fibers, and this may be a final common pathway because that seems to take longer than it does to develop pain. So you can get pain before you get this dieback. What is clear, the dieback is there in this type of neuropathy. There's these astrocytes and microglia that have been implicated. These are sort of the, if you like, the immune cells of the central nervous system, and they seem to do stuff and get activated that somehow relates to pain and dysesthesia and all the other signs and symptoms that we talked about. There's the activation of the TRP channels, these are the transient receptor potential channels, and we'll talk a bit more about that and how perhaps we can exploit that for treatment. And then this key thing that seems to be perhaps one of the main potential mechanisms that people are looking into is the mitochondrial stress and the generation of reactive oxygen species. So this is the epidermal nerve fiber loss that I talked to you about. So this is in the control. You can see the orange fibers into the dermis that are alive and well, and then you can see they're gone after oxaliplatin. Now, minocycline is an inhibitor of microglial cells, and if you inhibit the microglial cells, you seem to get sparing of that loss of the epidermal nerve fiber loss, which again sort of suggests that the microglia do have some real action in causing the neurotoxicity, the CIPN, and this epidermal nerve fiber loss. Now, there has been a clinical trial that's looked at the minocycline for this inhibitor of microglia compared to placebo, but as you can probably see from the straight line that there wasn't a significant difference. So that hasn't so far resulted in any meaningful treatment. So very quickly, the mitochondrial mechanisms bit. These just in summary, basically anything that causes oxidative stress in the mitochondria can worsen neuropathy, and anything that reduces that oxidative stress and the reactive oxygen species decreases the incidence of neuropathy and chemotherapy-induced neuropathy. So therefore, this seems to be, if you can prevent this oxidation, then this could be a mechanism by which you can prevent chemotherapy-induced neuropathy. And these are some of the things that have been implicated. I won't go into great detail. We are currently looking at a study, well, we just finished a study looking at mitochondrial DNA, which is DNA, as it sounds, from mitochondria that is released in the bloodstream, whether or not this is a biological marker for either severity of CIPN or prediction of severity of CIPN. So the mitochondria seems to be perhaps a key part to look at, perhaps an area where eventually therapeutic options will come out of. This is, again, using this, I'm not even going to say it because I can't pronounce it, but it's an agent that reduces those reactive oxygen species. So it's doing exactly what we said should hopefully reduce the neuropathy. And this is a clinical study. Although the authors did say that there was a difference, you can see the p-value is 0.17, so I'm not quite sure. Perhaps there was a non-significant difference. So potential maybe, and maybe area for further thought, looking at the mitochondria as a target to try and reduce the incidence of CIPN. So current clinical treatments. most of that which I'm going to talk about comes from this systematic review that has looked at everything that's got an RCT type level or less in sort of retrospective studies as well about CIPN. This was also what is known from the CIPN level about these current treatments: amitriptyline, nortriptyline, amitriptyline, cannabinoids, and gabapentin. As you can see, there's a recurrent theme here: no pain improvement and increased side effects. So the issue may be actually many of these studies looked at all comers of CIPN, and it may be that actually we have to look at the single agent CIPN because it can be all different. And that's one thing that I can tell you about CIPN is the only thing typical about CIPN is everybody's atypical. So even people who had exactly the same chemotherapy, exactly the same doses, exactly the same accumulation can get completely different sensory changes, completely different symptoms. And it's, as I said, it's all very different. Although that cobbles, walking on pebbles or cobbles, is a common complaint. So this is the study which the current guidelines are based on. This is duloxetine. Quite a big study, 5 weeks, and they saw the mean decrease in average pain was 1.06 on a Likert 0 to 10 scale compared to 0.34. So actually not fantastically brilliant. And the other thing that when I reread the paper, that was only present for the platinum, so only platinum-induced neuropathy, not for the taxanes. There was no difference to taxanes. So it's even less effective than I thought it was. But it's the only one that has RCT level evidence. Now, this was the ASCO guidelines in 2014, and they said yes, duloxetine, but they also said you could use gabapentin, pregabalin, tricyclic antidepressants, and opioids, tramadol, and maybe topical agents. But as we've heard already today, the updated version says for patients with cancer experiencing CIPN, clinicians may offer duloxetine, and that's it. Now, I would go down the commonly used phrase of saying no evidence of action is not evidence of no action. And we can look about some of the in other agents that may have some potential. And these comes from that meta-analysis or the systematic review, the laser therapy, electroacupuncture, percutaneous auricular stimulation, scramble therapy. I don't know much about these. There is some evidence, but sort of poor quality single study type thing. But I won't go into them because I don't know much about them, but they are potential treatments perhaps. What I do know a bit more about are the topical agents. I've already had menthol mentioned. Now, the level of evidence for menthol isn't great, but there is some case report type level by Leslie Colvin up in Edinburgh that showed that this was beneficial. And I would slightly dispute there's been no adverse events. I've had 2 adverse events. One person said they didn't like to smell minty, and the other one said they didn't like the way that their feet got soft when they repeated the application of the cream. Now, I'm not trying to be trivial about it, but actually, as far as side effects go, that's not too bad. And we use menthol a lot. And given that we used it initially at a dose of 0.05%, because that's the only thing I could get my hands on, and it clearly had no effect, and now we use 2%, and it seems to have an effect, I would say there is evidence of a dose response, and therefore I think a real effect out with that of placebo, although I'll take placebo where I can get it. The other topical things that we use, which there is some evidence for in neuropathic pain, so localized neuropathic pain, so we're extrapolating it from localized neuropathic pain to CIPN, is capsaicin. And there is some evidence for the use of the capsaicin patch, the 8% Qutenza patch, which there's a nice story which is partly supported by evidence and partly not, is that if you use a Qutenza patch, the 8%, so 1,000 times more concentrated than the 0.075% cream, then what you do is you get total dieback of those epidermal nerve fibers, and they grow back normally. That would be a lovely story if it occurred, but so far not yet. There is some evidence that the patches can help, although anecdotally we don't seem to get it to work very well when we send people to Chelsea and Westminster, and that may be because we're only sending the most refractory patients, so it may be an unfair sort of challenge for capsaicin to have to take on the most refractory patients. Local anesthetics. Now, this is why when I talk to patients, I say you have a mixture of nerves damaged doing nothing, causing numbness, and nerves damaged doing too much, causing the pins and needles, pains, burning, etc. Because when you talk to them about using topical local anesthetics, they're going, you're mad, because my feet are already numb or my hands are already numb. So that's why I take great pains to explain that we're trying to calm down those damaged nerves that are doing too much. Hence the local anaesthetics, such as the lidocaine plasters and or Emna cream, etc. There is a lidocaine cream, but we don't have access to that. And then if I've got time at the end, we'll talk about botulinum toxin as part of a case report. So I think my summary is not dissimilar to Mary's as it should be, because that's what CIPN is about. It is under-recognised and under-treated. It's certainly in our establishment, patients are consented, but when there's a lot going around at that point in time in a patient's life, they may not always recall that. And I've had people saying, if I'd known that I was going to get neuropathy, I would never have had the treatment, which is more reflective on how debilitating this can be. It is cumulative dose dependent, length dependent neuropathy, and symmetrical generally. And the problem is, one of the problems is there's limited evidence for treatment, and also there is some weak evidence for certain agents. The preventative strategies are also not well proven, and so far no learned body has put that in the recommendations to use any of these so-called preventative strategies. Mechanisms, I think, obviously will give us, well, hopefully will give us some targets we can look at, both for the prevention and the treatment. And as I said, there are many things going on, but maybe the mitochondria story and calcium flux is what we should look at. So I've got, yeah, so I'm just going to use a case report to exemplify a typical sort of, well, as I said, all patients are atypical, but this is just one example. So 56-year-old man who had adenocarcinoma of the colon, ex-professional cyclist, and this is a mixture of case reports, so there's no identifying features of this patient. Had oxaliplatin-induced neuropathy, had painful paresthesias and the feeling of walking on icy cobbles. He couldn't sleep, and that FAT-COG NTX 16 is significantly high, and the peripheral neurotoxicity questionnaire was D, which again I'll show you what that is. And he had severe pinprick hyperalgesia. So where I prodded him with a pin, he went ow in a big way, more ow than he would have done if I'd prodded any other area. So this is a FAT-COG. Again, similar to the other ones, there's the amounts a little bit, somewhat, quite a bit, very much in certain aspects, and we definitely concentrate on the NTX3 and NTX4 because it's discomfort in hands, discomfort in feet. And this is a patient neurotoxicity questionnaire. This is specifically for these types of neuropathy. There is another one for the other types of neuropathy, and it's no numbness, pain or tingling, mild pain or tingling, moderate tingling, pain, numbness, etc. And then also some mention of interfering with activities of daily living, which I think is good. So D would be up here. I have moderate severe tingling, pain or numbness, hands and feet, interferes with my activity of daily living. And then we have a subsequent sort of secondary bit that you tick the boxes that people are having trouble with. So this is patient-centered. It's looking at quality of life and activities of daily living, and it also has pain involved. So that's why we use it. And when we were seeing patients more before COVID, then we had this database upon which everybody CIPN did the FAT-COG and did the PNQ, as well as several other questionnaires. So the idea behind the doing that QST light, as I call it, that pinprick hyperalgesia, is in making some kind of mechanism assessment. This is actually from diabetic neuropathy, but CIPN is very similar, that if you have a stimulus here, this is in a normal, you get a bit of firing off, but when it's got this those damaged nerves that are overactive, you get this firing off. So there is a mechanistic assessment that makes you think that topical local anesthetic may work because you're calming down those nerves that are doing too much. And this is looking at the Botox. So what Botox does, and it's not to get rid of wrinkles, this is taken up by those damaged nerve fibers, goes to the body of the cell, and a lot of these processes that are involved in the pain of the CIPN are potentially reduced. Now, again, there's no direct evidence for chemotherapy-induced neuropathy, but there is in other types of localized neuropathic pain, and it's a subcutaneous injection of botulinum toxin A. So this is what we did for this gentleman. After many other things that helped, but he couldn't, or he didn't feel that he could get back to the cycling that he wanted to do. And so what we do, we map out the area of pinprick hyperalgesia and then inject in little squares. So normally about 20 injections per feet. We'll put a total of maximum 300 units of botulinum toxin A. And this is just to let people know, if you look on the picture on the left, that is a full bottle of Botox. I've had people throw this out because they thought they're empty. That's the Botox smudge at the bottom. And we did this for him, and he managed to get back cycling to what he wanted to do. He had been on other treatments as well, but the Botox sort of was the sort of final bit that helped a lot. So hopefully that case report has given you some idea of the sort of things that we can try. As I said, we basically use the neuropathic pain guidelines and we extrapolate it to CIPN. And although the actual evidence base of CIPN is pretty rubbish, as I've said, we do seem to help quite a lot of people with this mixture of topical and systemic treatments. And when we looked at it, from our RN database, about 80% of people, when they come back, say they've had a benefit that they regard as being meaningful. And I'm not saying that everything's gone away, but their patients' global impression of change has improved, and usually quality of life has to some degree improved as well. But there is that 20% where it's refractory, and they're the ones that we potentially struggle with, and they're the ones that tend to get the Botox, Hutenza, etc. And that's it from me. Another gratuitous picture of the Vallée Blanchet.
Looks fabulous. Looks fabulous. Thank you so much, Paul, for that run through. Funnily enough, I came across a patient in clinic this week who was having Botox for this. It's the first time I'd seen it. Too early to know whether it was doing him any good, but it's an interesting field. Can I invite Leanne to come on camera and Nate as well? We're running short of time, but I just thought I'd bring Leanne in from an AHP point of view in terms of the benefit of exercise and the physical side of approach to managing CIPN.
Yeah, so we would see patients, would assess patients, would advise what level of exercise they could do. I think looking a lot of the evidence around the peripheral neuropathy group is actually trying to strengthen proximally, so the sort of hip muscles, core muscles, and actually getting that strong, particularly if they've got balance issues as well. Obviously, with anyone going through chemotherapy treatment, we would advise gentle cardiovascular fitness exercise that they enjoy as well, which is going to improve their quality of life. So I think there's a combination, lots of sort of exercise advice that we could offer as physiotherapists.
Right. There's a couple of questions come through very quickly. One is about biomarkers for risk of peripheral neuropathy. And you mentioned in your talk, Paul, something about working at that mitochondrial level, I think.
Yeah, it's difficult because we're looking. This is proof of concept. Are these markers that we're looking at, do they have any mileage at all? The issue being, which some of the patients said, actually, so what if you know how severe my neuropathy is, or it's going to be? How's that really going to help me? Because it may reduce the chance of me getting treatment, etc. So we've got to be slightly careful exactly what we're wanting for. Maybe if it's used as a sort of accessing resources earlier. And there's no, at the moment, with no evidence of preventative treatments, but maybe there is, if we can get people, seeing these, both the pharmacological and the occupational therapy and the physio and all the rest of it, all at once. What we're trying to work on is a one-stop shop. So when you come to clinic, you get everybody there. But that's been, strangely enough, quite difficult to try and sort out, and including psychologics, almost like a pain management course, but for CIPN.
Yeah, I've just recently been watching some videos, which I'm going to look at it because I don't know the word. Maybe the nucleus accumbens is implicated in being a biomarker before starting treatment if somebody is at risk, sort of looking at the brain rather than the peripheries. Yeah,
the issue that we have, there's lots of genetic stuff that looks at links between CIPN. The trouble is all the markers that have been shown to be important or related, a bit like what? They're sort of strange proteins that nobody really knows what they're doing. So it's not quite as simple, or there's something that we know is associated with pain, and we know that it's associated with other things. So it's slightly jumbled up, and we're trying to unpick it to give us some sort of additional benefit and help for the patients.
Thank you. Just before I hand back to Lorna, I just want to point out the RM Partners website does have some really nice guidelines about CIPN. We're just looking at those at the moment. They were produced in 2019 to see whether there's an update required. But if you're looking for a resource, there is something on the RM Partners website. I'm going to pass you back to Lorna to conclude. Thank you.
Oh, thank you so much, Mary and Paul. They were both brilliant talks. Thanks so much. So thank you everyone for joining us, and please join us next time. You will be emailed a certificate of attendance and also a feedback form, and we really be grateful if you could complete that on timing, structure, any topics that you might want in the future. But again, thank you so much for attending, and we'll see you next month. Bye.